Hello, I'm Andrew Goddard, President of the RCP. I would hope most of you have got that by now. But welcome to one of our Let's Talk sessions. And I've got with me today Dr Ivan Beckley, who I hope you're going to learn lots about. But he has achieved a lot in a short career so far, but covered lots of quite interesting and challenging issues. So, Ivan, good to see you.
Good to see you too.
Thank you for taking the time. Do you want to tell us a bit about yourself?
Yes, absolutely. So, my background is I grew up in London. My parents are Sierra Leonean, so they grew up in West Africa. So I was the firstborn. And I grew up as a Londoner and managed to work my way through school as the first one to go to university, and then ended up at UCL studying medicine. That was a really long journey. But I would say still to this day, one of my proudest moments was going to medical school, because it's an environment where you're exposed to the opportunity to become a doctor and all the learning that brings. And so whilst at medical school, you go through your 6 years, and I was really interested in global health, in the challenges of delivering healthcare across the world, in the UK, and just learning from different places. Obviously, my parents are African, and so their journeys, experience in healthcare, how did that translate to the UK was really interesting to me. And so I studied global health in my third year, and that was fantastic because I was exposed to anthropology, health policy, and all of the things that impact healthcare that isn't clinically related. And then I became drawn into data and technology, and my dissertation was on health information systems and how they are so important in helping us to understand how healthcare works. And so I ended up actually taking a year out of medical school to do a master's in data science. And that was also at UCL, so I didn't go anywhere, which was basically looking at how do we utilize data as a way of supporting people when we have staff shortages. Hiring is really a big problem in the industry. Using technology to support the people in the system was really the goal. So I finished the master's and then went back to medical school, and that was some of the most memorable experiences were in those final years, where you are practicing more independently with support from the clinical team and really picking up your clinical skills. And then graduated last year, and my journey from there has been to really think about how do we apply technology in healthcare in a really meaningful way.
Brilliant. Now, some people watching may know, but you've done a podcast.
Yes.
The bias diagnosis,
yes,
which is a bit challenging. I think it challenges a lot of how we think. Do you want to tell us a bit about that?
Yeah. So the bias diagnosis was a podcast I did in partnership with Audible. And the intention of it was basically to create a narrative and a story around people's experiences which are unheard of. Yeah. And these are mainly ethnic minorities in the healthcare system, and how their experiences of healthcare is very different to others. And we wanted to tell a story around, one, what their day-to-day is like, but also create a context around where does this come from. So we speak to experts and researchers to really understand actually why there is this bias in healthcare that is related to skin color. Where does it come from? Why does it still exist? And why do people have these experiences that are so visceral in the system?
So was there any particular patient that sort of really sort of stands in your memory as sort of made you take your breath away and think this is something we all need to learn from?
Yeah, I mean, I think going through the process, the thing that really informed me, and the thing that I always take away was those stories. And it's the same in medical school, the things you don't forget, the patients you meet and their backgrounds. And there is one patient that stands out, actually. Their name is Toby Adebayo. Their story is actually of starting off experiencing pain and how difficult that pain was for them to have that recognized. So they started off having dislocated joints and really going through an experience where they couldn't really explain their pain. And their story is really compelling because actually when they came to the UK and met doctors who were very dissimilar to their background, in that they grew up in Nigeria, they had a better understanding of actually my experiences are not the same as others. And their story then unfolded where at 21, they were diagnosed with hypermobility syndrome. And we know how difficult it is to diagnose that syndrome, but it took them a lot longer to get there. And then their story progresses from that syndrome to being diagnosed with endometriosis. And then they were very excited about the opportunity to have a child, and then finding out that that child had sickle cell anemia, and then having to also reconcile the fact that pain is unfortunately a symptom if things don't go correctly. And they were very aware of actually their experiences, and how they didn't want their child to also experience the same. So their story is really compelling to me because it's a journey of growing up and having to experience pain, mistrust, misdiagnosis, and then having a child who potentially they would have to experience, hopefully not, but at the back of their mind was, would they go through the same experience that they had?
Thank you. Yeah, very powerful story indeed. Yeah, thank you. So you've clearly been a medical student.
Yes.
And I think it could be argued that medical school sometimes doesn't prepare you for some of these debates.
Yes.
Certainly for white males, I would say.
Yeah.
So how do you think we could improve medical school to ensure people get a better understanding of the issues of bias, both conscious and unconscious?
It's a really good question. I think I would say this: medical school is filled with so much to learn, and there is so much to understand in order to become a doctor. And so in order to really understand bias, we have to first ask the question, what still needs to remain in the curriculum? Because we can't put things in without taking things out. There's just, I've been through it, there's a lot.
Yeah, there's a lot.
As you have as well.
Everybody wants something. So
Exactly.
Yeah.
So the thing I like to think about is, what can we bring in that, or rather edit in a way that we can better understand these things for medical students? And really, I think it's about who medical students are exposed to in their teaching. So really looking at who is teaching some of the curriculums, who are given opportunity to lead on teaching, and really looking at the diversity of the people who are teaching, because that is a big part of what papers we read or what we get influenced to, and the studies that we understand. And I think that's unconscious bias is really important to be aware of. I think the second thing is really exposing people to different ethnic minorities and backgrounds. So really looking at where we're placing people in their environments and placements. I went to UCL, and so that exposed me to all walks of life and individual. But I'm sure at other medical schools that isn't the same. Yeah. And I think helping people when they're going through medical school be exposed to different populations and actually be challenged in different environments, not just in the general practice or in hospital, but also in community services, because often social services and those alike are a big part of how people experience healthcare who are from ethnic minorities. So those are some thoughts that I've had, but I think it's definitely a challenge for medical schools to be able to think about how do we bring in teaching that helps to address some of the biases in the system. And one of my good friends, Malone Mukwende, he had a book around skin color in medicine, and he also did it whilst at medical school. And medical schools have adopted it widely as a way of basically addressing some of the gaps in our learning.
Yeah, the historical whiteness of medical textbooks.
Yes, exactly.
So when you talked about that, so I remember a fantastic lecture I saw Michael Marmot give when talking about how do you get not only doctors but medical students to really get to grips with some of the issues in health inequalities. Yeah. And some medical schools actually get their students to live within communities who are the most deprived, because certainly I was, very middle class in my upbringing, and a lot of the things and the problems that I see now as a doctor, I had no experience of. Yeah. But actually exposing people to that as medical students, I think gives people some really interesting insights and does change the relationship. And I think it gives power away to the doctor, which the doctor-patient relationship can be quite a power relationship at times, and we need to work against that. Okay, that's all fascinating. So what do you want to do next to build on the podcast?
Yeah, when we created the podcast, a big aim of mine was what happens next. We create all this context and this content that people can consume and understand. At the moment, we've taken it as an approach. So I've worked on a number of talks and conversations. I've worked with my own medical school to share some of the content, and today, I mean, personally, I've been lucky enough to be on now the board of an NHS hospital trust, Barnet, Enfield, and Haringey. So I'm associate NED there, and I think a lot of the reason why I was given the role was based on the work that I was doing with Audible, and we're working on a lot of the workforce challenges, and also thinking about how do we address such a diverse population in Barnet, Enfield, and Haringey. And so that has been my approach to taking the work forward, is actually being in positions where decisions are made, where we're able to influence the way things operate in the NHS.
Yeah. Has that been surprising to you, seeing it from the other side, so to speak?
Extremely. I think when I walked into the role, I had a sense of the importance of non-execs in the NHS and how they influence the system. But really it was, one, just how much there is to deal with. The various committees, quality and safety, audit and risk, and really understanding how complex the system is. I think when you're training, you're operating, you see the care, but there is so much more to the way everything is delivered in care. And also just how diligent the governance is for the NHS, and the documentation and the information that's created. And so I think having insight into the complexities, one, gives you a real sense of how, I guess, hard it is to run a successful hospital in the system, but also that there are people in the system who are really trying to move the needle bit by bit. And it's not, change doesn't happen overnight. It's just not possible.
Okay. I mean, when I was at your stage, I wouldn't have had a clue what a NED was. I'm very impressed. It's like all these things, it's a tough job. It's, NHS trusts are huge organisations, and to be able to make sure that it does its jobs, many of which are legally enforceable, is impressive. Okay, so can we talk a bit about widening participation, which is something that's quite close to my heart. I would love to be able to get more people from different backgrounds into medical school. The challenge is then, of course, that a lot of it is based on your academic performance. We have got fairer in how we select our medical students. But how do you think we go further?
Yeah, I mean, widening participation is really important to me because that's how I came to medical school. My first introduction was through a widening participation program at UCL, coincidentally. And that was when I was 15 years old. And if it wasn't for that, I wouldn't be here and have studied medicine, because before, my mindset of what it meant to be at medical school was that it was for someone a lot smarter than me. It was for someone who had a lot more access to the system, understanding how things work than me. And so when you're exposed to those programs that I was on, things begin to break down. You begin to understand, actually, I can be that person who can apply and be successful, and just demystify the whole process. I think going to medical school can feel very daunting. You have to do a lot more than other courses to be in a similar position. So that was really helpful. To your question as to, what could we be doing more? There's so many things. I think there's been a long way from when I started in terms of really investing in looking at access and looking at grades and looking at where people come from, and not just having a blanket rule on how people come in, and really adjusting some of those offers depending on people's backgrounds or their circumstances. I think that's a very more equitable approach to providing access to training to be a doctor. I think also being very diligent around providing opportunities for people in the community. So I think one of the biggest barriers, and I still speak to students who are applying, is just understanding what it means to study medicine. And I think hospitals have been doing a good job, and general practice also, about providing opportunities to students who maybe otherwise wouldn't have an opportunity to, as I did, sit in a clinic, just down the road, and really understand what doctors do day to day, because there are some documentaries and there are some TV series, but it's not the same as the real thing.
And one of the challenges is that, people get exposed to medicine if their parents are in the health service or doctors, and many people don't have that, that generally get in through the widening participation program. So we've got to spread our net much wider. And you almost describe a kind of imposter syndrome. You feel you're not really good enough. Which many people feel throughout their careers. So we just got to make so that people shouldn't feel like that.
Exactly.
But in some ways, it's understandable why people should feel like that, because the system is set up in such a way that we can break. Okay, that's fascinating. You have mentioned through this a bit about workforce, and you'll know that workforce is something that I and we are passionate about, trying to do something about, particularly with medical school places. But you've been doing some work sort of in your remarkably successful career already, and you are CEO of a company called Suvera, which sort of has solutions to the workforce in mind. Exactly. Do you want to tell us about that?
So Suvera came out of medical school and really observing the challenges in the system. And so my friend and I we went to medical school, and I think our passion for technology led us to really start the company. So Suvera as a company, what we do is that we are a virtual clinic, and we partner with general practices across the country to look after patients from home. And the reason why we did that is because one of the biggest challenges for doing that effectively is technology and building that technology to do it. Because we have some tools which are useful, but they don't quite go as far as we think they need to go. And so today, we're operating with about 20,000 patients across the UK, with over 30 practices. And we're learning a lot. We're learning around the challenges of working in partnership with primary care. And we're learning about the challenges of integrating systems for it to be effective and not, fragment care, which is a big challenge with technology. So those have been some real achievements that we've had. And I think the reason when we started, we didn't really think what we were solving was workforce challenges, but that is what we are solving, in the sense that most of the practices we work with, their biggest challenge is retaining and hiring staff, and especially in areas which are really hard for people to, I think especially in areas where it's really difficult to find people with the right skills and motivation. So we really help to actually have a virtual workforce, in that there is a pharmacist in Manchester who's looking after patients in North London. And that is not something general practice can do by itself, but we help them to do that really effectively.
And what's your take? So I think one of the challenges we've got with digital technologies moving forward is that there is a risk they could widen health inequalities. People having access to the kit that works, also having the skills in order to use those tools. What's your take on that? Yeah,
it's by far one of the biggest challenges we have in delivering this service, and really that's the pushback we get from general practice and primary care. Is, as a result of bringing this, are we giving access to some people and not to others? Are we improving outcomes for others and worsening for other people because of access? And we thought a lot about that. One of the biggest challenges was people who said, I can't buy a blood pressure machine. High blood pressure is what we manage primarily. And so we provide free blood pressure machines to whoever needs one. And that's always a surprise to patients, because they feel like, because I don't have what I need, I can't get what I want from the healthcare system. We don't think that should be the case. We also do a lot of work in the community. So we sponsor programs for people to learn about how to utilize their computer, or how to access their phone, or in order to not only just engage in our service, but also to engage with other services that are increasingly becoming digitally enabled. And I recently am now working with a charity called Community Tech Aid in South London, which donates and recycles used laptops to people who don't have. And those have been very intentional things, because my worst fear was that in doing this, we actually make health outcomes worse for some people. And so it's something that I think in any delivery of technology, we have to have as top of the list, as in, we can provide it to those who have access, but what about those who don't? They shouldn't miss out on that same quality of care.
And how are you going to build on that? So that clearly you can increase the reach, and you've got whatever is 20,000 patients, and double by the end of this year. Let's be bold. Are there other things that you would like to get into? You say you've learned a lot about data in your career to date. What other things would you like to get your teeth into?
Yeah, I mean, there's so many things. Where do I start? I think one of the things that we're really interested in is bridging the gap between primary and secondary care. And I think that's increasingly becoming part of the agenda, is how we have a more joint up approach to delivering healthcare. And the thing that I'm really interested in is how do we bring specialists closer to the community. So we're beginning to think about trials around having, at the moment we have pharmacists managing high blood pressure, but could we have a similar registrars kind of managing referrals for early cancer suspicions, or pain, or dermatology, for example, but led by a specialist. So bridging that gap is something that I'm really excited about, or really interested in doing, just because of the long waiting list that we have in the system. And I don't think there's anything we can do unless we try something new to really fix it.
Okay, I've been throwing questions at you. Is there anything you want to ask me?
Yes, there is actually. I would love to hear from you about, what do you think is the biggest opportunity in the system for addressing inequalities in healthcare?
Okay, so I'm a bit like you, I'm a data geek. So I think firstly the biggest opportunity is recording stuff.
Right.
And that's really quite hard.
Yeah.
And we've been doing, trying to get people to declare, what their ethnicity is, for example, is really hard. We sent a survey out and got sort of 8% giving us answers back. But data is power. And therefore understanding where the gaps are and what you need to focus your attention to is part of it. I think you have to engage with lots of different people. And one of the things that we did here before the pandemic sort of was think about that, and then during the pandemic with the summer skill review, we had an opportunity to get, and Ben got secret shoppers to come along and effectively sort of test it. And that was really good, because you get asked the questions that you don't think about. And you can then actually be quite sensible about what do you need to do to make a difference. And I therefore think if we're going to change medicine and how medicine is perceived, we've firstly got to know what we're doing right, what we're doing wrong. We've got to ask lots of people to contribute to that, but then we've actually got to just do it. And I think there comes a point where you actually, you know what needs to be done, and you've just got to crack around and do it. And I think medicine is getting there. I think one of the challenges is that because it's so generational and people in medicine for a long, long time, so one of the things that people say is, well, we know that over half people in medical school are women, yet only a third of consultants are women. But that, in some ways, that's history, because as the demographic changes, it then has to work its way through the system. So we have to accept that it's not going to be, but we have to be sure that we're going in the right direction, and be very aware we don't move the wrong way. So that's what I think we need to do. And I'm constantly inspired by people who've done it well and influence. And I think working with people like Ben Summerskill and just talking to you, you realise how you and how we as a college can be better.
Yeah, amazing.
Grand. Okay, well, I think we probably need to draw things to a close there.
Okay.
It's been brilliant talking to you. Thank you. I feel slightly in awe, and I know that you've got a fantastic and great career ahead of you.
Yeah.
If you had the chance to talk to yourself when you were looking towards medical school in 2014, any advice you'd give your own self?
Yeah, I think the main advice I would give is to trust what you feel is right. I think I went through medical school seeing things and problems and thinking, oh, someone should probably solve that. That's probably too big for me to deal with. And I think when I started to actually believe maybe I could be the solution to the things that I wanted to see, I think then I started to really lean into the power that I have to influence things. And I think believing that I would tell that individual starting medical school again to believe what you think is right.
Yeah, good advice. Very good advice. Well, lovely talking to you.
Nice to speak to you also.
Take care.
Andrew.